like to get started now with our lunch and learn. I want to welcome everybody here to the UofL Physicians and University Hospital Lunch and Learn today. We're really glad that you're here with us. I'm Elizabeth Walden, the Communications Manager with UofL Physicians, and we're pleased to have Dr. Michael Weaver here with us. He's a PM&R trained specialist. He's board certified in physical medicine and rehab and also in sports medicine, and he's going to talk to us today about carpal tunnel syndrome.
Thank you. Can everybody hear me okay? If I don't have a mic or anything right in front of me. And you'll have to bear with me. I'm fighting some sniffles and a little cough. My little girl got me sick, so at least I think it's her. So if I have to take a drink or something, you have to excuse me. But so we're here. We're going to talk a little bit about carpal tunnel syndrome. Since my time in training and practice, sometimes this can present with some curious symptoms. That's what I wanted to point out, which may not always be carpal tunnel related, and they kind of get overlooked or shuffled into a certain category with that. So I want to make sure you guys are educated on what carpal tunnel syndrome is, what types of symptoms patients have with that, how we can treat it, and hopefully educate you a little bit with that. So to start every lecture, usually we want some objectives. So this is for you guys to become familiar with the basic anatomy of the wrist and causes of carpal tunnel syndrome. There are some risk factors that are associated with it. Obtain a better understanding of the signs and symptoms associated with carpal tunnel syndrome, and become familiar with some of the various testing that we do for it, and then the treatment options. Also along the way, if anybody has a question, I can stop and raise a hand. I think it's pretty informal like that. I would be happy to take questions during the talk too. So a little bit of background. Entrapment of the median nerve, which is the nerve that's in question during this syndrome, is most common and best characterized peripheral compression neuropathy. And so what that means is, our nerves, as they're coursing through our limbs, the arms and legs, sometimes they're subject to sites of compression, where pressure on that nerve will cause some symptoms in that distribution. So this is the one we know best about. It's the most common. Prevalence of it, sites vary and the data varies, 0.1% to 10% of the population. So a little bit of a gap there, but about 2% of male, 3% of female, and some sites will say it's about 3% more common in female than males. But the myth that I think is out there a lot is a lot of times we associate this with work-related conditions, and the data really isn't out there supporting that. We do see higher rates in repetitive wrist types of activities. So people who are typing a lot on keyboards, I know is the common one. Butchers, those who are doing vibratory type of things where their hands are going to be vibrating a lot. In athletes, we see it in tennis players and rowers. There is some thought that cumulative trauma and repetitive compression may lend to some carpal tunnel syndrome, but that doesn't, it's not fully supported right now. The interesting thing is about 50% of people have bilateral carpal tunnel syndrome. That said, only about 38% are actually symptomatic in both hands. And so when we get to the testing a little bit later, we'll do testing on both hands, and typically we'll find that one is worse than the other, but it's definitely present in both, and they weren't really aware of that because they didn't have any problem that they perceived. So that'll guide our treatment choices and kind of the options available to them. So some risk factors. The main pathophysiology or the cause of what's happening as the nerve's being compressed is increasing pressure within the carpal tunnel. That said, some conditions and medical conditions support this, can actually increase the susceptibility of the nerve to be more sensitive to those pressures. Peripheral neuropathy, if anybody's familiar or heard that term before, that condition can lend the median nerve to more susceptibility to those pressures. So I think the thing to point out, normal pressures when we're looking at pressure in the wrist is about 2.5 millimeters of mercury. This is just to put a number up there for you guys to see the comparison. In carpal tunnel syndrome, we'll see that resting pressure about 32 millimeters of mercury. And then just with a little wrist flexion and extension, so back and forth, that's going to jump to almost 100 millimeters of mercury. At that pressure, nerve changes to the structure and coating of the nerve, the lining of the nerve, which we'll talk a little bit about, are already going to start seeing some changes. So it can start happening fairly quickly when we'll see some breakdown of the nerve structure.
Dr. Weaver, how's that measured with that?
Through a manometer, so a pressure manometer, we'll put in a needle, and these are studies that have supported this, but we'll put in a little bit of saline and then it blasts back and then lets us read the pressure. Similar to how we do compartment syndrome testing and different things where it's a needle manometer, so it's recording pressure from that region. Yep. So contributing factors, this is not all encompassing, this is just listing a few, but pregnancy, thyroid problems, chronic kidney disease, acromegaly is a problem with growth hormone secretion as people are developing, diabetes, obesity, smoking, alcohol abuse, inflammatory arthritis, and just your genes, how your nerves are made and how mom and dad's nerves are made. I think the common theme amongst a lot of these is fluid changes. So during pregnancy, you'll see fluid fluctuations, kidney disease, diabetes. So that swelling is what we're thinking will lend more pressure to that region. So that's why we'll see those symptoms become more prevalent during that time. So what's happening to the nerve when it's being compressed or that pressure is actually increasing? A lot of fancy words up there, but there's really not a better way to say it initially. So it actually inhibits axonal transport. So the signal that's being sent down the axons, they're the part of the nerve that's carrying information from a stimulus to then the muscle or skin for sensation. Epidural blood flow. Nerves need blood just like any other part of our body, really. That compression will then result in edema within the nerve, so swelling, thinning of the myelin, we're going to talk about that in a minute, and then degeneration and fibrosis of the nerve. So a little bit simpler, it's impaired nerve circulation, diminished elasticity, so there's some inherent elasticity to that nerve, it starts getting a little stiffer, and then decreased nerve gliding. So when you're moving your joints, your arms, these nerves are kind of gliding in and out of that region and going back and forth. They need to be able to allow that change. And when we're seeing the compression, it doesn't lend to that as well, so we'll start seeing these changes within the nerve fiber. So a couple depictions of it, just showing, I think the top one up there shows a little bit about the swelling that we start seeing. We're going to go over the anatomy here in a second, but that's the transverse carpal ligament, so that's the ligament that's in question, when we start talking about the space available in the carpal tunnel. And that shows just some swelling of the nerve proximal, so just before it passes through it. The bottom one here, I think, is a really good picture of just a nerve and the parts of it. So the nerve itself is, a bigger structure. If you think of a piece of spaghetti and then thousands of little hairs running in that piece of spaghetti, which may not be good to eat, but it's going to be kind of the structure of a nerve. So those hairs are encased in fascicles, and then each of those are encased in bigger groups, kind of like this shows. Excuse me. And so when we start seeing compression, it's going to cause damage to various parts of that structure. Does that make sense to everybody, kind of how the nerves look there? And so this is another depiction of what's happening when we have compression. So a normal nerve here on the left. As you have compression, you're going to get sheath loss. So that's the myelin that's coating the nerve. What the myelin's doing is allowing the nerve to conduct its electrical signal, in a speedy and good fashion. It's going to get to the target with the biggest size of that electrical impulse that's being transmitted down there. So if you start losing some of that myelin, it's not going to be able to conduct it as quickly. You start seeing some slowing of those electrical impulses. Eventually, with prolonged compression, you're going to see disconnection of that nerve, and then it's going to start degenerating. So it breaks apart, and then you have to have regeneration and healing that takes time after that if we get to that point. So the key is avoiding, hopefully, that part of the nerve injury phase. So a little bit about the anatomy. What is the carpal tunnel? The median nerve travels beneath the transverse carpal ligament, which is what I showed you there before, really with 9 other tendons. So there's 4 tendons to the flexor digitorum profundus, 4 tendons for the flexor digitorum superficialis, and the flexor pollicis longus. So those are 9 in total. FDP, FDS for short, they're the ones that are bending the knuckles. So your knuckle there and then the far one. Those two, the mechanism of action for those muscles. So after it passes through there, it's going to provide sensory and motor input to a portion of that hand. And we're going to talk about that here in a second. So as another good depiction, as the nerve passes underneath the transverse carpal ligament is when it's going to then start innervating a lot of the hand muscles as well as the fingers. Classically, it's going to innervate 3.5 fingers, so we say digits 1 to 3 and half of D4. So your first 3 fingers over here and then half of your ring finger towards the thumb side. And then on that, I think this has, so on this part over here, here's just all those 9 tendons and then the nerve. The nerve sits most superficial, so it's sitting towards the top of the skin there. And if we get a lot of pressure, what we're saying within that space, it's going to push up and cause compression on that nerve. So the clinical features that we see with this is pain, numbness in digits 1 to 3, like I said, and really half of digit 4. You'll get sparing of sensation to the thenar eminence. This is really kind of the base of the thumb and the palm. And so the important thing with this, we're going to go over here in a little bit, it's supplied by the palmar cutaneous sensory branch, which is a branch off the median nerve, but that nerve actually hops off before the median nerve passes under your transverse carpal ligament. So sensation should be preserved in the palm of the hand in patients with strictly carpal tunnel syndrome. The problem is when patients come in and what they complain of is really vague complaints. They feel that their whole hand is numb. Usually they'll start saying, I'm feeling sharp pains just around the wrist and it's shooting up my forearm to my elbow. I've had people come in complaining of just shoulder pain and achy pain, and it turns out that it's more carpal tunnel, not necessarily a problem in their shoulder. So 50% of the patients actually reliably localize their symptoms, and it's not because they don't want to, it's just it's the nature of what's happening with that nerve. Now the important difference is, so neck pain is not an associated symptom. So if someone's starting to say, I'm having a lot of neck pain, this is shooting down through my upper part of my shoulder here, that's not an associated symptom with carpal tunnel syndrome. It should be a red flag to start looking kind of towards other things with your physical exam. A couple other pictures. I think this just shows the space well. You got all these tendons in there with one nerve. And then this is just showing really the distribution, and this is actually incorrect because this part of your hand really is supplied by this guy that's hopping off right about here. So that should be intact. You're really going to get the fingers and the thumb. So what happens with the symptoms? Classically, patients will say that they're more frequent at night, so nocturnal predominance to the symptoms. They'll awaken them from sleep, and this is actually a positive sign. It's a flick sign. So they'll say, I wake up and I'm got to shake my hand out. It's simple enough name for that sign is a flick sign. Usually, when you're driving, talking on a phone, you'll start seeing worsening symptoms or exacerbation of that numbness. And then later on, as this kind of goes untreated, they'll start noticing, hey, my grip's a little weaker. I can't hold my keys. I'm dropping things. I can't hold my coffee cup. And these are all kind of just common things we see with progressing carpal tunnel syndrome. So what do we do when we look at patients and do an examination? I think the big keys are on visual inspection. So first, just take a look. These 2 pictures depict a lot of what we call thenar atrophy. So you can see we describe it as scalloping. You almost took an ice cream scoop and just kind of takes off some of that muscle, and that's just wasting of that muscle that's supplied by that nerve. Usually when it gets to this stage, it's pretty fairly progressed, and both the sensory and motor parts of the nerve are being damaged. We'll look at strength, so strength to the thumb and some of the hand, and then sensation. Most resources will recommend really light touch and pinprick. Those are the 2 more sensitive kind of things to look at to determine sensation. Other ones would be vibration and 2-point discrimination, so just being able to tell between 2 separate points. Different parts of the nerve are communicating those signals. I think that the light touch and pinprick is going to be more sensitive for what the carpal tunnel impingement or compression is going to cause. And then provocative maneuvers. So all that means is what can we do to actually bring on the symptoms? And if it does happen, then more likely that it could be carpal tunnel syndrome. Now the catch is these provocative maneuvers are not, we look at sensitivity and specificity of these. You know, if you do it, how sure are you it's going to be that condition? None of them are very high in either regard. They're fairly limited, so you kind of take all of these pieces of the puzzle and put them together. But the common ones we use are Tunnel's sign, so we'll go over these here in a second. Phelan maneuver, and then there's a reverse Phelan, and carpal compression, which is also known as Durkin's compression. In medicine these days, we're getting a little bit away from named exams. I think they're wanting to just have a more general terms rather than it's named after an individual who started using it. So here's some demonstrations of those. This would be a Durkin's or the carpal compression test. And on the bottom right there is a Tunnel sign. All you do with Tunnel's is you're going to gently tap over that median nerve. And you don't want to do it too hard, but if you feel like, hey, I'm getting these zings that are sending right into these 3 fingers, it might be some carpal tunnel that's happening there. Compression test is you just hold compression over that area for 30 seconds. And if that results in symptoms, then that could be a possibility as well. And these two are Phelan's and reverse Phelan's maneuvers. So Phelan's is actually on the right, and so you'll just have people flex their wrists, and you get them up and hold them about 90 degrees. So you kind of hold them here like this and just let them sit there for about 30 to 60 seconds. After about that time, they'll start saying, whoa, yeah, it's getting bad. I'm feeling these paresthesias or numbness in those fingers, or the pain is getting worse. And reverse Phelan's is just opposite, obviously. So both of them can exacerbate the symptoms, though. So some of the masqueraders I just want to point out, these are the uncommon, I guess, symptoms that are usually presented with carpal tunnel syndrome, and these would be other lectures in their own right. But pronator syndrome. So if someone would come in and start saying, yeah, my whole palm's numb, and it is numb on exam, that would lend you to think the compression or the injury to that nerve has to be higher upstream than at the wrist. Because if you're thinking of anatomy and where these nerves are coming off, like we talked about, it's coming off here in the arm. So if that's being affected, then all of a sudden we're going up to the elbow to think that maybe it's getting pressed there. And so as the median nerve comes through the elbow, it actually passes through 2 parts of this pronator teres muscle, which pronates our arm. That can be pinched there too. So occasionally we'll see both sides being pinched, that actually it's getting pinched here and at the wrist. And so surgeons would release both sides. A lot more rare than carpal tunnel syndrome. And then the other one, which is important that we always teach residents and patients about, is a double crush syndrome. And so what's happening with that is actually you're having involvement of a cervical nerve root, so a pinched nerve in the neck that's causing symptoms in a similar distribution in addition to then at the wrist. So it's important not to overlook, because you could release a carpal tunnel all you want and the symptoms won't get better unless you go maybe look at the neck and make sure that nothing's happening up there too. C6 and C7 are the nerve root levels, so the neck levels that's being affected. Bottom line, a thorough history, physical exam should be able to delineate between all those and help hone in on what site is most problematic. So to establish a diagnosis, it's important that this is truly a clinical diagnosis. We do things with ultrasound and electrodiagnostics, which help kind of give some insight to the severity of it, but that's not the sole diagnostic point. It's this constellation of symptoms. So as patients coming in, the exam supporting that they're numb in those digits, weakness of those associated muscles, and then we use these tools to really confirm that. So with ultrasound, musculoskeletal ultrasound, it's kind of an up-and-coming thing that we're using a little bit more because it's non-invasive. Gives you real-time visualization of the nerve. So you can actually just place a transducer or an ultrasound probe on the wrist and be able to look at what the nerve looks like. And so this is a picture of it over here. They had it outlined. There's the median nerve. I don't know if you can see it as well on this, but transverse carpal ligaments coming right up over here. And then so the difference between, and it doesn't come up as well, between the top and bottom, so this would be more abnormal. So what we see is swelling around the nerve. So you'll see increased fluid around or within the nerve. You can measure diameters of the nerve both prior or after the carpal tunnel and seeing if there is changes in that. I think it's a good tool to be able to give good visualization of the structures, and then we also use it in guiding injections. So I think the next phase of medicine, as we keep getting better at what we're doing, it's going to be knowing where we're putting the medicine. So one of the things we'll do is injections, and we're going to talk about that here next, but doing it what we say blindly versus having something that allows you to actually see where your needle's going and put the medicine in, I think it's going to be kind of the next phase of things. So, electrodiagnosis, this is another study, and we do it as physiatrists or rehab doctors, and neurologists are another group of physicians that will do these studies as well. There's two components to it, a nerve conduction study and electromyography. So the nerve conduction study is actually just what this is showing right here. So we put these little sticky things on different areas of the skin that we want to record that nerve signal from, and then use a stimulator to actually put in an impulse or an electrical stimulation into the nerve. So it feels like you're getting pinched really strongly. Some people say it feels like if you touch an electrical fence, but it's quick and gone, a matter of a millisecond that impulse hits you. And what we're able to see is really how fast is this nerve sending the signal across that segment. And when does that signal get to the sensory part of the nerve as well as the motor part? So the one doing sensation as well as then the one doing strength to the thumb. And we can look at both parts of that. Sometimes the sensory fibers are the only ones affected. That's really early on in things, and that can guide your treatment options. Later on, you'll start seeing the motor involvement too. So it really lets us better characterize, I think, the injury that's happening to the nerve. This is just a representation of actually what one of the waves that we see and what we're getting with those studies. So the electromyography portion is then a pin or needle portion where we're going to put a little pin into the different muscles of the hand and possibly up the arm. That lets us look at really the health of the muscle. What kind of signal is it getting from the nerve? Lets us look at all the nerve roots coming out of the neck, and we can hone in on, is it just this nerve causing problems to this muscle, or is it a nerve root in the neck that's being pinched, and now we're seeing it in multiple muscles through the arm, and that would obviously change your treatment. So both parts are important to do. When I get patients referred for that study, I always say it's not the funnest thing you're going to do. It's not the worst thing, though. I know that I've heard there's a lot of YouTube videos of these things that are out there, and they're frightening to people. So I haven't watched them myself, but it's not that bad. And I think it gives you a lot of good information from what you can get from this study. So, the question is, what do we do about this condition? What are the best methods to hopefully get symptom relief, prolong the need for surgery, which would be the ultimate goal. We know that once you need surgery, and that's the definitive treatment, potentially are going to need surgery again maybe 10, 20 years down the road. And we know scar tissue forms, things heal back. It's possibly that carpal tunnel syndrome will return at a later date. So we want to try and buy time up front to avoid that. So what measures do we do? Just activity modification, try and change what makes it worse. Wrist splints is really the mainstay, I think. It's what we prescribe a lot, to put a resting wrist splint on, and I'm going to show you a picture next. But it's designed to keep your wrist in kind of this neutral position, because once you start getting flexion or extension, you'll see that kind of compression start happening. So the easiest thing for wrist splints is to just start them on a nocturnal basis. So wear them when you sleep, because all of a sudden you have 6 to 8 hours where you can keep this wrist in a neutral position and hopefully give some relief and healing to that nerve. What people usually don't think of is when they're sleeping, they pull up or they pull the covers up and they do this. Or you roll over on your arm like I do, and then I wake up, my whole arm's feeling numb. And that's a good way then to wear these at night to hopefully avoid those things from happening and hopefully give some good healing time. Corticosteroid injections, pretty common. Usually these do very well. For a duration of time, 3, 6 months or even longer, if we hit it right with the injection. Ultrasound therapy, so this is actually not diagnostic, it's doing therapy with ultrasound. Nerve gliding techniques, these are treatments therapists will be able to educate patients on. It's putting the arm, really, if we're talking about the nerves in the neck and arm, through certain ranges of motion for various nerves. So the median nerve will have different ones than the radial nerve or ulnar nerve, which are other big nerves in the arm. And hopefully that's going to help the nerve start gliding. Any adhesions or sticking points, roadblocks along the way through the wrist, we're going to start working those out a little bit. Medications are out there too. Vitamin B6 is really the hot one that a lot of people think is going to help with nerve regeneration and kind of healing. Non-steroidal anti-inflammatory drugs versus oral steroids. The research will favor oral steroids. Again, this isn't necessarily an inflammatory process that's happening. So if you take Advil or Aleve, probably isn't going to help much with the symptoms you feel from the carpal tunnel syndrome. Now, if you had some inflammatory arthritis, like we talked about before, that may help calm that down, which subsequently will help bring some of the pressure off of the nerve. But research currently would favor oral steroids, but then that again can cause fluid changes, and people tolerate those medicines differently. So,
since you're pinpointing specific spots, what about the anti-inflammatory creams?
that would be a good option too. But again, and that would be more for than if there's a associated tendon problem or arthritic problem, not necessarily for the nerve. And so I think it's just a distinction to make, because it's not inflammation within the nerve that's happening. So the anti-inflammatory wouldn't bring out the inflammation within the nerve, but within the joint space or within that wrist. Yes, yes, the synovial lining. What's that? Yes, but so the carpal tunnel syndrome is more from the pressure on the nerve because of increased pressures within that region. So that's causing nerve kind of degeneration and irritation. Not necessarily that I pulled a muscle and now I got swelling and inflammation, which that would be more, along those lines, or arthritic problems for that matter. Yes, sir?
You see baseball players and weightlifters wear a glove with a band around their wrist.
Right.
And they're always making it tighter. Does that help or hinder carpal tunnel? Or is it neutral?
So he's asking about some baseball players that are, wearing all the tight bands, or, some of the athletes that have tighter things around the wrist. I see this a lot with weightlifters who use wrist straps. Actually, from my experience, makes it worse. And what we're seeing is because it's increasing that pressure during that. So the example in my mind is really the weightlifters I see, these power lifters, and they wear these tight wrist straps. Then they come in, like, my hands are just numb as heck. I can't, and I, try and encourage them to limit the wrist strap use first.
Why do they do that? What's the advantage of that?
Well, right. And for the lifters, it's the support. They want to give some better support to the distal radial ulnar joint, so that part of the wrist. But yes, it's kind of a give or take. Do you want to be able to have the support, or do you want the nerve to be suffering? So, and then ultimately, so surgical release is kind of the definitive treatment that we talked about. Two methods that we see, open versus endoscopic, and I'll show you a couple pictures of both of those. So these are the more conservative methods. This list over here, if you can read it, these are actually, I found this off the internet, but there's a lot of herbal supplements and things. Vitamin B6 we had talked about, but pineapple, willow bark, cayenne, because of the pain relieving properties. We see that with capsaicin cream. But some of these things may be worth a try. I think, when I develop these treatment options for patients, if we can throw the kitchen sink at it, I would do that before we would say, hey, you need surgery or you need something else done. I would exhaust every measure possible. Over here you see that in the wrist splint, this is just you can get these off the shelf anywhere, Walgreens, Walmart, any drug supply store. Just basically to keep the wrist in a neutral position. And a lot of them will have a little firmer stay. Some have a little metal stay kind of built into them, or plastic, which is going to give some more support to that part of the wrist. And then here's just a picture of the injection. So this is kind of where it's localized at, but we're injecting right into the carpal tunnel there with a little corticosteroid and anesthetic. So that's really done well for most patients, when we get to that point. But again, we kind of exhaust all the other measures before we say, all right, let's do an injection and try and buy some more time. And then these are some pictures just of the surgical methods. So over here, just an open release. You get a little bit bigger incision because of that. And then the endoscopic release, which would be down here, there's usually just a portal site that then they'll place the endoscope in to try and release the transverse carpal ligament. Both of them are designed to just basically snip that ligament and try and open up the space, is what they're doing. Neither of them have different outcomes that any data has supported yet, that one's better than the other. The research shows that possibly with the endoscopic, it's hard to get a full release of that whole ligament, but you have faster healing times because it's a smaller incision. You don't necessarily get as much stiffness through the wrist too. So as you heal, you'll start seeing some scar tissue and adhesions forming. Yes, sir? Healing time after a surgery? I mean, it varies because there could be other medical conditions that could, prolong healing. I would say usually after about 6-8 weeks, things should be, from the skin and structural standpoint, healing up. But you're still going to have, some time till you're back to using that hand the way you would need to possibly for your occupation. What we do see though is after a release, we'll see some immediate changes and recovery of that nerve if that compression has been persistent for so long. So just some referral information. So this is our group, with the University of Louisville Physicians. We're physical medicine and rehab. Most of us in our offices are stationed over at Frazier, but I do see patients too on multiple sites. This would be a number that would get you to clinics if you would need that. We're happy to see any complaint, musculoskeletal condition or problem. So if you have concerns or people that are having concerns with some numbness or paresthesia, as we call them, tingling, it's better to get it checked out earlier than later, I think, just like with anything in medicine. If we can practice more preventative medicine, I think we'll see better outcomes down the road. So that's the bulk of it. Are there any questions or thoughts? Yes, sir?
Surgical release part of the ligament. Ligament actually serves purpose. You can't just cut it open.
Well, they do, and I'm not the surgeon, so I won't be able to answer you, probably as specifically as I'd like to, but you are providing basically a release and opening of that ligament. You do cut it. You still have other structures that are tethering, and you got skin covering and everything else with the other tissues. So it is released. You do basically snip it.
You cut the entire ligament.
Yes, yeah.
So does it change the function of
No. We're not seeing any change with wrist or digit use, no. Yeah. Yes, ma'am?
Is texting increasing
Yes.
It may. What we are seeing with texting is a little bit more of thumb arthritis and some other problems with tendons in the wrist. So I think it's going to be more implicated in some other conditions that we're seeing in particular. But yeah, doing this a lot, if you get some thumb arthritis, you're going to have more, swelling and then pressure in that region. So it's definitely possible.
Do you find people wait too long to get treatment and the nervous?
So questions, if people wait too long typically, my experience has been about 50-50. See, I have people that come in for testing, they get referred for electrodiagnostic testing, and their hands look like that picture I showed with the wasting. Where it's just basically a bone there. And they obviously had put it off too long. Most people, I think, are better on the front end. They feel like something's not right, and once they start dropping objects, or they're noticing it more in their daily activities, combing their hair, blow drying, drinking coffee, driving, telephone talking, it becomes more of a nuisance and aggravating factor, so they get evaluated sooner. But. Mm-hmm.
So is this disease reversible, or unless you do surgery?
Well, so it depends. We do the things to try and relieve the pressure and keep the integrity of the nerve is the bottom line. If the nerve has so much compression chronically that there is degeneration and basically destruction of that nerve, some of those changes are then irreversible. Before that point, though, yes, and once you do injections or you're doing the therapies or then ultimate surgical release, that's going to be, reversible, I guess, effects on the nerve. So you can actually let it heal and start recovering a little bit.
So once you stop the treatment, does the nerve go back to the enlargement, or does
You mean if we're doing like conservative measures and different things? It just depends on what the aggravating source or factor would be. So if you are adhering to activity modification, you're able to avoid those things, then hopefully, yeah, it'll stay better. The problem is within the occupations and different things that we start seeing, you know, the requirements of people, it's gonna come back eventually. We're still trying to decipher a lot of that and see why some people are maybe more predisposed than others, and if that's more genetics or then the medical conditions that are, you know, owing to that. Mm-hmm.
Is there a correlation between the carpal tunnel and effects of arthritic thumb? Because I'm experiencing both. So my question is, if I have the carpal tunnel surgery, which I actually called today to schedule it,
Okay.
Will there be any benefits to the arthritic issue with the thumb?
I would say no, ultimately. I mean, so the base of the thumb arthritis, which is maybe what you're referring to. So we call, you know, arthritis, like any condition, your body's trying to fuse the joint. So it's basically trying to protect it. It thinks, hey, this is painful, might as well fuse. And so that's all, and it's just a progressive process. We have no cure for arthritis. You know, we take the anti-inflammatories and those things to try and help. So just by releasing the nerve, you'll have improvement in sensation and then hopefully strength for the thumb. That said, it's not going to change the joint itself. So once that narrowing happens, that happens. Now they do joint replacements for the thumb, you know, which is actually kind of, you know, a newer thing that they're doing now. So that would be the definitive treatment for thumb arthritis. But injecting that with steroid and stuff too, if you haven't had that done, I would, you know, consider that.
I have posted exercises for my phone, computer staff. Do you support those? Well, I remember one of them was this. And
That's a nerve gliding technique that you just showed there. Yes, yes, absolutely. I would say that those are worth performing and trying to adhere to. Yeah, yeah. And then being mindful of ergonomics, you know, and that's the key in having good education. So.
well, I
yeah.
had the OT staff down to see that they were positioned right and had the right
Yep.
way of support.
Yep, perfect. Yep. Anything else? I hope it was informational for you. Thank you for bearing with me.